The views and opinions expressed on the Healthcare Advocate Show do not necessarily represent the views and opinions of Connoisseur Media or its advertisers.
Everybody, this is Sharon Gauthier from Revolution Healthcare Radio. Thank you for joining us. A lot has happened since last Saturday. That was our first show. We had some great call-ins. I have a guest today that I'm very happy about. And I am very happy to also talk a little bit about our sponsors that we're very fortunate to have. You know, when it comes time to go outside of the family for help with a loved one, you really want people who are the best people in home care in order to help you. And home helpers in home senior care happen to be three people who came to me when we first talked about the radio show to want to sponsor it. We were very impressed with these three gentlemen. There are three franchises that we're working with. One is in the Farmington area, the other in Enfield, the other in Wallingford. And what I liked about them is that their story, the personal story, was quite compelling in that they really did this from the heart. They all had experienced having loved ones that needed home care at home, which is different than home health care, which we'll have a show on at some point. We worked with them in the past, and we recommend them to our clients for full or part-time aides. They have home health aides. They have certified nursing assistants, and they actually are very involved with their employees and the care that they provide your loved ones. So we would highly recommend them, home helpers. The phone number for that is 860-698-2244. You can call for a free in-home consultation. HomeHelpersHomeCare.com is also their website, and we will be happy to have all three of them on our show next week to talk a little bit about what home care is and what it isn't. Today, I'm very happy to introduce my guest, Peggy Sayers. I've known Peggy in a number of venues in my life, and she is one of the few legislators in the Connecticut legislature that's a registered nurse. Hi, Peggy. How are you?
Sharon, thank you so much for having me today, and I look forward to our talking today on healthcare.
Well, Peggy has had, she's the chief deputy...
Deputy Speaker.
Deputy Speaker of the Democratic House. And Peggy has been on multiple committees, one of them being the Public Health Committee that I have read testimony on several times. And we were going to talk a little bit today about healthcare in general in the state. But as Peggy and I were coming in together, I had said to her that all over Facebook this week was the Views comment regarding a nurse. And many of you probably have seen it. Apparently, the Miss America Colorado contestant came on as her entertainment and came in scrubs and a stethoscope. And she talked about her life being a nurse. And apparently there was a comment made by Joy Behar on The View as to why she did this and why she was wearing a doctor's stethoscope. So as you know, there are over 3 million nurses in the United States. This generated a myriad of comments, and I thought today's show, in addition to other things, we could talk about that because I know a lot of my colleagues out there who are registered nurses understand what we do and what we don't do, and that we certainly work in collaboration with physicians, but we're boots on the ground. I actually took from Facebook a letter that a surgeon wrote that I wanted to read, but I also wanted to tell everyone, all of my colleagues out there, if you could please call in at 888-574-2723. That's 888-574-2723. With your comments, your concerns, I think out of everyone in healthcare, nurses are probably the most challenged right now. Would you agree, Peggy?
I think so, because they have the bulk of the care of the patient, whether you go to a hospital, a nursing home, or home care. It is the nurse that actually plans your care and provides that care for you.
And I think that nursing has... Excuse me, I was just taking a drink of water. I think nursing has gone through a lot of changes in the last 5 or 6 years with the computer system coming in, which my view of the electronic medical system really is to protect the system. As a registered nurse and being in management, I've been involved many, many times with the transition into computerized documentation. And I really found that what it did was limit nurses to really input actual items that were happening. And I always felt it was to protect the system. The only part of the EMR, the electronic medical records, that I really viewed as being a benefit for everyone, and all of us have been there, Peggy, in 3 nurses sitting around trying to figure out the handwriting of a doctor for a prescription. So in that way, I think that the EMR's electronic medical records have been an absolute salvation for all of us, that you don't have as many errors. But what's interesting is that there's still a lot of med errors that happen.
Yes, and one of the things that I find fault with electronic medical records is that it really should be the patient's record. It shouldn't be the hospital record. It shouldn't be the doctor's record of your care. It should be yours. And actually, the one thing that the VA health system does do right is you get a credit card type of card, and that has your electronic medical record. So wherever you go in the VA system, you can slide that card through, and then you have your medical record that actually belongs to you and has the history of your care on it.
That's very interesting, because as you know, through the years, there's been a big protection of records, and I always felt that it was the system protecting themselves against anyone having access to it. And I think there's still a struggle with that. Our organization, our service that we have, part of what we do is conservatorships. And I've actually been in a hospital with a patient that I am conservator person of, and have been denied the record at the time, including their discharge summary on the unit, and have been redirected to medical records. And what has happened is that I've had that nurse, usually that brand new nurse that I've already scared to death because I've asked her for this information, that will come back to me with a HIPAA release form from the hospital. And in this instance, I said to the nurse, I think conservatorship of person from probate pretty much trumps the HIPAA release form. But I still wasn't able to get that discharge summary for that patient leaving. I had to go to medical records. So as we struggle with trying to make our system a little clearer for everyone to be able to understand, when you're in instances like that, it just makes you wonder, why can't I have the discharge summary? Like if this was a family member who had come in from out of state, was bringing their loved one, back home, they would need that documentation. And to be told that you can't have it because it's their record really doesn't make any sense.
That's very interesting, because one of the pieces of legislation that passed this year actually requires hospitals to tell families what the discharge plans are for that patient, to actually spend time with the family and go over that information with them. Because so often people come home, and when they arrive at home, the family really doesn't know what they're supposed to do. And the other point is the conservator of person. A lot of people really don't understand that, and the difference between that and appointing someone as your healthcare decision maker. The conservator actually acts in your stead. They are you in every sense of the word, making those decisions, and I think people don't understand that.
Right, and I don't even think they understand power of attorney. And I will at some point have an attorney come on and talk a little bit about this. But when the system recognizes that there's a power of attorney, they will often say to the patient, or the spouse, well, we can't talk to you because we have power. There's a power of attorney, which isn't true. If the person can talk for themselves, they absolutely can ask questions and be spoken to. And I agree, it's still a mystery and a lot of education needs to be done. Again, I would encourage everyone to please give us a call. I have Peggy Sayers, who's a registered nurse, one of the few registered nurses in Connecticut that is at the legislature. And our number is 888-574-2723. I just want to take time now to read this letter that came on Facebook. As I said, there was a huge amount of discussion talking about the comment that was made on The View, and a lot of responses from everyone. The one response that I felt the most compelled with came from a surgeon. But first, I want to talk a little bit about Protein Sciences. Protein Sciences is also one of our sponsors. Protein Sciences is a company in Connecticut, and they actually have developed a flu vaccine that we're very excited about, and we're sponsoring flu clinics for them. And the flu season's coming soon. Dr. Minot Cox will be on our show on October 3rd to talk a little bit about it. Flublok is a flu vaccine that has absolutely no additives in it. And if you're allergic to eggs, you can also take it, which is great. Flublok is better, safer, more effective. If you think because you're young and healthy you don't have to worry about the flu, you need to think again. If you are exposed to grandchildren, you should be getting the flu vaccine. If you are over the age of 60, you should absolutely be getting the flu vaccine. Flublok is the only licensed flu vaccine, does not use eggs, antibiotics, or the influenza virus in any part of its manufacturing process. So that eliminates any response you might think that you have from the flu vaccine. So I would follow up with your doctor and look for flu clinics to try and get to a flu clinic and get yourself a flu vaccine. Dr. Minot Cox suggested that really the flu vaccine should not be given before the end of September and October. People who ran out and got them from their local pharmacy in August because they were advertising them are usually the ones that are going to need that booster. When you get Flublok, you don't get that booster. So I'm going to read this letter, and I'm not sure who it's from. He did not identify who he was, but it is a surgeon, and what he said is that it's from an ungrateful, selfish, arrogant surgeon. Surgeons for years have had reputations for being a little difficult, as Peggy knows, to deal with in the past. But I thought his response to this comment about the nurse wearing a doctor's stethoscope was very poignant. He said, yesterday I posted a silly photo in support of this movement, but tonight I want to say something serious while there's ample attention. When a patient comes to our hospital for surgery, these are the people who take care of them. The pre-op nurses meet the patient, make sure they are ready for surgery, complete mountains of paperwork, reconcile medications, sign permits, check labs, answer questions, allay fears, and make certain the patient is properly prepared for surgery, and they put up with me. The circulatory nurse is in charge of the OR. She makes certain, and I'd also like to say that it could be she or he, even though he referred to she. The pre-op nurses meet the patient, make sure they are ready for surgery, complete mountains of paperwork, and reconcile meds, sign permits, check labs, answer questions, allay fears, and make certain the patient is properly prepared for surgery, and they put up with me. The circulatory nurse is in the OR. She is in charge of every detail, where the implants are, the equipment, the disposables, the medications. Every detail is ready. She oversees that everything is checked twice, that everything is documented properly, and that the proper surgery is performed on the right part and the right person. Her job is to ensure that we do everything right, from with no exceptions, every time. She makes certain that every sponge, needle, gauze, blade, specimen are properly accounted for, and she puts up with me. My CRNA, which is actually a certified registered nurse who's a anesthetist, puts the patient to sleep and attends to them through every moment. She listens to every breath and heartbeat. She makes sure that they are asleep, safe, and comfortable. She holds children in her lap and talks to them like a mother while they go to sleep. She makes certain that every patient goes to sleep and wakes back up as safely as possible, every time, no exception. And she puts up with me. The people who we operate directly with are nurses or techs, not doctors. They make sure we have the proper instruments and equipment. My scrub hands me what I need before I ask for it. She can anticipate what I'm going to need next better than I can many times. She makes my job easy, and she makes me look like I know what I am doing when sometimes I am less certain. The person across the table from me is often an RNFA or an SFA. They operate directly with me, tie the knots, cut the sutures, retract, hold, pull, control the bleeders, close the wounds, and a million other things. They simply could not do what I do. I simply could not do what I do without them, and they put up with me. The PACU nurses, which is where the patients go after surgeries, take the patients from the anesthetist and recover them from anesthesia and surgery. They assess and dress wounds. They treat pain, anxiety, and fear. They hold screaming babies in their arms till they are awake. They hold hands of grown men who are disoriented and fearful. They reassure the calm the patients, children, spouses of their patients. They give wound medication and discharge instructions, and they transfer patients to their room. They land the plane, and it's an important job as any in the world, and they put up with me. The nurses in the ICU and the floor take care of the patients, not me. The ICU nurses are infinitely more capable of monitoring and assessing sick patients than I am. I try to stay out of their way and let them do their job. They let me know when they need me. The floor nurses take care of every detail of every patient, what and when they eat, medications, wound care, ambulation, checking vitals, labs, weights, sugars, pulse oximetries, intake and outtake, draw and take labs, start and restart IVs, and countless other things that only nurses understand. They spend time with the patient and family all day. They educate and answer questions. They pray with the patient and family. They cry when the patient dies, and they put up with me. The truth is that if a patient is in the hospital for 48 hours, they may see me the smallest fraction of that time. I say a brief hello before surgery. I operate and I speak to the family and make rounds each morning. I spend 15 minutes each day at any one patient's bedtime. The rest of it, every second, every bit, every detail, everything is performed by the nurses. Honestly, the one who probably needs the stethoscope least is me. And at the end, through it all, they put up with me. Thought that was a very good letter coming from a surgeon.
It was very gracious of him to write that, but the matter is, it is the truth.
It is absolutely the truth. And again, I would encourage my colleagues to please call in and discuss a little bit about what you do in nursing, what your role is, what your concerns are. Like I've said, I think that nursing is in the biggest change right now. Our number is 888-574-2723. Whoops. Listen, sorry. I just dropped something. This is what happens when it's a real show in real time. So, Peggy, until we start getting some calls in, I wanted to talk to you a little bit about the Public Health Committee that you've been on for a long time. How many years?
Well, I've been 18 years in the legislature, and all but 2 of those years I've been on the Public Health Committee.
So I know last year there were a lot of discussions on public health about medical assistants expanding their role that didn't end up going through. There was a lot of people speaking for and against it. I'm not sure if that's something that you think might come up again this year, or what is your sense and feeling about that whole concept of expanding the role of medical assistants?
I do believe it will be back before the legislature in February when we start our session. There was discussion. The problem was that we couldn't get everybody to come to consensus. And the truth of the matter is, in other states, the medical assistants have a much more expanded role. The major question was around administration of medications this time. And in Connecticut, what the legislation would have done would have been allowed the medical assistants to administer the flu vaccine. So, as I said, there was no consensus on it, on what education should be part of it, how far we should let them go in terms of medication. But I think that will definitely be back in this next session.
I think my apprehension about it last year when I spoke at the legislature, as well as some of my nursing colleagues who are in education, which I used to be a professor in a college in teaching nursing, was really the fact that the physician practices have changed, and it's really around volume now. So although the concept of having a hospital own a physician practice sounded great on paper many years ago, and all based really around cost, what it's turned into is a mandate for most of those offices to see 28 to 30 patients a day. So when you think about that kind of busy office and having a medical assistant manage medications, it concerns me because the discussion was that the physician or a registered nurse would be overseeing them distributing those meds. It's been my experience that most offices don't have nurses in them. So it would be the physician who's busily seeing 28 to 30 patients a day, that the medical assistant is quickly going to come in every time and say, is this okay? And they say yes, until it ends up not being okay and someone's done something that they shouldn't. So I guess it's the oversight that's probably going to be the challenge once it is passed. Because I agree it's probably going to pass, but then what will be the oversight of that?
Right, as well as the educational component. One of the problems was that we do allow unlicensed staff to become med certified in a few settings. And actually, for instance, in group homes, you will see unlicensed staff. But nowhere in the system do we allow anybody to give injections, with the exception of the EpiPen for an allergic reaction. And the EpiPen is set up so that anybody can administer that in that emergency.
Right.
So,
and the EpiPen, for those who may not know, are for when someone has an anaphylactic reaction to peanuts, break out in a rash, can't breathe, or whatever else they might be allergic to.
Right. And so because we don't allow injections, I had some concerns. This was going to take us a little further afield than we had ever been before. And one of my long-term concerns is, as we look to ways to have savings in healthcare because of the cost, that they would expand this. And instead of nurses, for instance, going out to administer insulin in the home to people who can't self-administer their insulin, you would have nurses' aides doing that. And that really opens the door for a lot of problems and a lack of a good assessment of that patient that they're caring for.
And who's really accountable at the end of the day? You know, for me, as I and many of my colleagues worked in the system as nurses over the past 20 years or more, what we saw was more unlicensed personnel come by our side to take over tasks, and it was really just a task for that unlicensed person. But then the licensed person is responsible for them. You know, and when I worked on a surgical unit, I found it very difficult to monitor that, because I remember once getting a post-surgery client whose blood pressure was under 100, and because that unlicensed person wasn't aware that a blood pressure that low with a heart rate that was high was an alert and a red flag, it was something that I ended up picking up later, and, you know, was an example of a person not really trained to understand what that meant, what those numbers meant. So I agree with you. I think that once we start opening this door, and there is a huge need, you're absolutely right. With the elderly population out there, with home care agencies struggling with medication management, where do you go with that? With someone who needs to have insulin, for instance, even though there are pens that you can just turn, they're not allowed to give insulin to anyone. So it falls back on the family.
Yes, and it becomes much more difficult because home care, we're changing in Connecticut. We're trying to move towards more home care. It is actually better for the patient in that they can stay in their home and be cared for in their home. But to find a source of payment, who pays for the home care, it's very limited what Medicare or Medicaid actually cover in terms of home care. And who provides the care? Do we have enough nurses out there to provide care? Do we have enough home health aides? It's a struggle every day for agencies that provide that care to have adequate staff so they can cover the number of patients that require the care.
Absolutely. And I think that home health aides and certified nursing assistants are difficult to find really good ones. The programs have shortened. When I worked at Capital Community as a professor in the nursing program there, they used to grab us in order to teach the CNA program. And what I found happening is that my class started off to be 20 people, and then before I knew it, it was 40 people, and then it was 60 people. And they weren't great choices that I would have made for some of these people going into this, that were being encouraged to going into this. And a lot of them struggled to take exams. And then when they didn't take the exam right, I would be told, give them their exam again. And almost felt like we were just pushing them through. They wanted to shorten the program. So there's a whole group of people out there that have the title CNA that the agencies are comfortable with. And so they come in and they hire these CNAs thinking, well, they're a CNA, we don't have to do any training, until they actually end up with a client with complex issues, and they do have to do training. So it's a place that we're going to have to go to, but it's going to be a challenge across the board because it's basically an unregulated business right now. The home care agencies are unregulated.
Well, there's the licensed side and the private side. And the private side is more the companions and homemakers, and they send in home health aides, which currently today is not regulated. However, the licensed side of home care agency, where you have nursing staff making visits, and they're not only licensed by the health department, but they're regulated through participation in Medicare and Medicaid, then there are definite rules for that, for supervision. But I will tell you, the turnover in the staff of the home health aides is very difficult. When you have someone that's really good, it's because they're going to school and they're looking for a part-time job, and they're going to be gone as soon as you get them really well trained. And then you have others that are no call, no show, and people that are depending on them, and they don't come and they don't call, makes it very, very difficult to really help maintain people in their homes and have them safe.
And I think the agencies are all struggling with that. The agencies are anywhere from people that they have come in that are a 1099 or one that is an employee of theirs. But recently there was a law that is going to in effect, I think, in October. Can you talk a little bit about that? Because it's really around the home care agencies and the aides and the CNAs that come in. And again, everybody, I just want to give you our phone number. If you could please call in with your questions and comments, I'd appreciate it. Our number is 1-888, hold on a second, 1-888-574-2723. And Christian, we need to keep him awake. So keep that phone ringing, guys, so we can get some questions. My nursing friends out there, please call. We'd love to hear your comments about the stethoscope. So Peggy's going to talk to us a little bit about the new law.
And actually, the law that comes into effect in October is federal legislation, which allows, which addresses overtime pay for home health aides and live-in aides. And one of the problems that I've heard from agencies is that it's going to increase their costs to the point where they may have a difficult time to continue to exist and provide home health aides at the current rates.
So anyone working more than 40 hours a week gets overtime?
Well, and it also addresses whether you work more than 8 hours a day and how they address the fact that when you're a live-in person, that you have to have the 8 hours of sleep time and time off during that period of time, that you are never really employed for 24 hours. So how is that addressed in terms of overtime pay, and what is the weekly cost of maintaining somebody in their home with a home health aide? And really, it's much less expensive to keep someone in their home because you're not paying the room and board cost of a nursing home, but you still have to have the staff there to assist that patient to manage in the home. So how it will all play out, I'm not really clear, and I think there is a great deal of concern in the industry right now on how this will be.
Well, and I think continuity in a few of the groups that I work with that provide home health aides that I've spoken to about this, one of them being Hope Helpers, is that the continuity is gone. So for many of our clients who need 24-hour care, it's been great in the past because we've been able to arrange with an agency that we have two caregivers. So someone with dementia, which is often the case, or Alzheimer's, can have two people that they know. And they go back and forth. Usually someone would stay in for 2 to 3 weeks, or they might stay in Monday through Friday, and then they have a weekend person. So that continuity of care is huge with someone with dementia. They know the person, they know how to manage them. Now that's really impacted the agencies because no longer can that person stay, and now there's a bigger transition of multiple people coming and going, which is difficult to manage in terms of just the schedule, but also I think really unfair to the client that needs it. So it's a work in progress, I think, and I didn't realize that was federal.
Yes, it is. And the funny part of it is that, in dementia, as you mentioned, one of the big red flags is to have all those various changes in the healthcare worker that provides help to that patient. The continuity of care is so, so important when you're dealing with someone that has Alzheimer's or dementia. And the other thing is I have found, I worked for the health department for a number of years as an inspector, as someone who went in and inspected long-term care facilities for the type of care that they provide.
Did.
I did, yes.
I was offered that job when I was looking. I remember saying to them, I am the wrong person, because I would probably be trying to shut everybody down, and they just kind of chuckle. But that's a hard job.
It is a difficult job. And, of course, as people will tell you, they have extra help the days we're there to observe care.
Yep.
But you still can tell when there are problems, when care is not being provided, because the long-term effects of that care not provided also show up.
Correct.
In the declines in the patient. But one of the things that I determined then was patients would tell you they love it when they have the same aide caring for them, because she knows how they like their covers fixed.
Right.
She knows how they like their food fixed. She knows which clothes that they like to wear and how they like to do things. And so when someone new comes and they have to show them all over again the things that they like, it becomes much more difficult. There's that very, very special relationship when you have the same aide caring for you day in and day out.
Right, and knowing the triggers that might upset them. People with dementia have an anxiety component that when there is a change is when it'll escalate their behaviors, and knowing how to de-escalate that. I remember having a new aide that went in on a weekend with a client of mine, and I knew it was going to be a new aide for the weekend, young girl, and she called me saying that the client was really upset, crying hysterically, could I come over? So I went over to visit, and what happened is that the client asked where her mother was, and the aide said, your mother died. So in the client's eyes of dementia, what she was hearing was that her mother just died. So it brought her to a hysterical place that we had a long time to calm her down because that aide didn't really understand dementia. And so we were able to calm it down. But it's little things like that I always say to people, you need to go to the place they're at and not try to bring them to your reality. And on that note, I wanted to share a little personal story that I have about a very good friend of mine that I had lunch with. But first I wanted to talk a little bit again about flu block. Flu season's getting close, guys, and you really need to think about getting a flu vaccine. You can talk to your doctor about getting flu block specifically. You can go on the flu block website. It's proteinsciences.com to find out how to get it. It's a better, safer, more effective shot. It's called FLUBLOC. Actually, I think it's BLOK. The great thing about it is a licensed flu vaccine that does not use eggs, antibiotics, or the influenza virus in any way in its manufacturing process, which limits anybody's thought that you would get a reaction to it. And it lasts longer. So people who had to get that second shot last year, you wouldn't have the efficacy of this vaccine has been proven that you don't need that booster. So for all of my elderly clients and all of the flu clinics that we are supporting and sponsoring, which I'll bring that list next week, I would encourage everyone to try and get the flu block vaccine. It's covered by most insurances. The cost of it is $40 if it isn't, but it's a good investment. So again, the flu season is coming. Please think about flu block. So I want to share a personal story with you. I have a very good friend of mine, and she and I went to nursing school together. She and I have known each other for over 20 years. We went through her husband's very difficult cancer, he had esophageal cancer, and she's one of those friends that you talk to often, but you never got together often. You know, that friend that you see every 2 to 3 months, you have lunch. We always met at the piano in Nordstrom's. That was our place. The piano isn't there anymore, but we still, when we talk, I'll meet you at the piano. And we would go and have lunch, and we would normally close the stores. We loved to shop. We would pick out, silly lingerie with feathers and leopard skin and kind of look at each other and say, wouldn't this be nice, and had a good time together. So I had not seen her in a couple months, probably about 3 months. So we met up on Thursday. And when I met her at the piano, I didn't even recognize her. She was totally anorexic, no makeup on, and this is a woman who, early 70s, she always had makeup on. And I looked at her and said, oh my God, are you okay? You're so thin. I'm fine. She said, I'm fine. The doctor says I'm fine. And I was just really taken back. So we went and had lunch, and it was very clear to me during lunch that she had a form of dementia. There were topics that we would normally talk about that she knew nothing about, couldn't remember her son's name, kept saying, oh, I need to write things down. We did a little shopping, which was difficult for her. I watched her try to pay for something. And then she told me she had a new puppy and lived nearby the mall. So I said, well, why don't we go see your new puppy? I had started crying while we were having lunch, and she got angry at me and said, look, if you're going to go around and tell people I have a problem, we need to leave now. So I kind of got a hold of myself and didn't continue on with that conversation. But when I got in the car, I fell apart. I called her daughter, who's a good friend of mine, and yes, indeed, she's being worked up right now for a very fast change in her cognition, and they're not sure what it is. B12, as you know, is a very important vitamin that you need, that can create some of this. We went to go see the puppy, but it really bothered me for a couple days, and I was very tearful about it. And it made me realize, even though I'm involved with this every day, I talk to families every day about how to manage this, yet I became that family where I no longer have that friend. She's now a new friend, and I probably will be a new person every time she sees me. So I share that in that it's another experience in my life as I'm getting older, and another another piece of information now that I will have to be able to share with my clients, but have a better understanding. I've been doing this a long time. My mother had dementia, didn't affect me the same way, but I really was touched by this and would encourage everyone to continue being your friend. She will still be my best friend. She's not going to be the same friend. She will continue to be my best friend. So as we move forward, when I will have time to be able to go and talk with her and not cry about it, I will continue on with her. But I don't know whether or not you've had any similar experiences with dementia, Peggy.
I have. I've got a couple of friends that I see that are getting a little bit beyond that forgetful phase in terms of memory, and, continue to search for names of people that, they can describe everything about them, but the name has totally eluded them. One of the things that the legislature has done is required training in dementia or Alzheimer's, which is a form of dementia, in all settings, whether it be in the hospital, a nursing home, assisted living, or home care. And I think that's so important, especially when you talked a little bit about the aide that wasn't familiar with aspects of caring for someone with dementia. I think it's so important as we go forward that people are better trained in how we care for our elderly. As people live longer, they're more likely to have dementia, although not everybody does get dementia.
But memory issues do become, every time my husband forgets something, I'm like, oh my God, I'm going to have to bring out my tools and assess you. It's a little bit more than forgetfulness. And so when you say training, when the last I knew that there was 4 hours required a year of training for people who worked in the healthcare system. Has that hour amount changed, or is that?
No, it's still the same, but it's more than, it's a requirement. So we're going to see more and more of that training. And as we enter into the healthcare system, we're going to see that more and more people are trained and are actually dealing much better with people with dementia than they have in the past.
Because I always say to people, like with this aide, she had a lot of experience with dementia, but she'd had no training with dementia. So she may have had the person with dementia, like this woman's husband, where he sat on the couch and watched TV all day and, would go wherever you directed him, but he wasn't a challenge in any way. And then you had his wife, who was a huge challenge. We used to call her the axe lady because she got upset over the channel changer. I knew channel changers would always be a problem. So she went downstairs and got an axe. She was going to axe the television because he wouldn't change it. And the aide called me in a panic. I'm like, well, take the axe away. It turns out that she had a urinary tract infection, which creates a lot of behavior components. So, I think, and again, I was very pleased on Monday morning that I received an email from the media department from St. Francis Hospital. I love that hospital. I graduated from St. Francis School of Nursing.
Me too.
I have some very good friends over there, and I've been working with them in the ER. Patty LaMonica, good friend of mine. She and I have talked a lot about people with dementia entering the ER and how we manage. This is Revolution Healthcare Radio, because we're all in a bit of a revolution, and it is with Connecticut Talk Radio. You can go to ConnecticutTalkRadio.com. You can find our show. It will direct you to the website. I think that it's about time we started talking about all these things that a lot of people aren't talking about. So, again, we're here with Legislator Peggy Sayers. She's a registered nurse, one of the few. Peter's also a registered nurse, I believe.
And Teresa Conway. And we have one physician in the legislature. And so for a body that makes so many decisions around health care, that's very limited. So I hope that more nurses and more people in health care would definitely get active. Talk to your legislators. Let them know what's important to you. This is really important in how we do legislation.
I absolutely agree. And I thought about running for office But then after I spent my practicum for my graduate degree at the legislature, I realized that I would probably be in the news every other day, so I'm not quite sure that they would want that. So you are listening to Revolution Healthcare Radio, and this is Sharon Gauthier, your host. I'm a registered nurse, and we have on Peggy Sayers today. Our number is 1-888-574-2723, and we'd like to hear from somebody. Nobody's calling. My friends that I'll text you this morning with this number. Get on the phone. Start asking us some questions about anything. I wanted to talk a little bit more about home care. And if you need a home health aide for yourself or family member, Home Helpers is really one of the best. They're a new franchise in Connecticut. We had long discussions and spoke to them about our feelings about home care. One is that I do not work with home care agencies who have registered nurses in them because it's non-medical. So you shouldn't have a registered nurse, one of my many pet peeves in life. I've spoken to Jonathan Harris, who's the Commissioner of Consumer Protection, and they register, it's not a license, they register home care, homemakers and companion. So companies that I work with, kind of follow the rules. They don't take their job lightly. They've seen what can happen when you hire a person or a company that's not reputable. Over the years, they've seen patients and families where money's been stolen, missing payments, injuries, falls. I had an aide, actually, that was with one of my clients who was from an agency. She was an employee, which the requirement, as you know, for the agencies that they do a background check. I had some concerns about her and did a background check myself and found out that she had several, she's on probation, had several larceny charges, and I had medicine and money missing. And when I went back to the company, they said, we did do a check, but we wanted to give her a chance. So you have to be careful, right?
Yes, absolutely.
Have to be careful. Listen, we have our first phone call today. Mary from Meriden, how are you?
Hello.
Listen, welcome to Revolution Healthcare. And what are your comments or questions today?
Okay. What I want to state is that my husband is in a nursing facility, and he has dementia and Parkinson's. He's been here for a little over a year, and the care that he is getting is horrendous. He is manhandled with bruises all the time on him. He tells me he's manhandled. He can get that much out of him. And the first 7 months he was here, he fell out of bed 10 times because he wasn't being watched carefully. I just found this past Thursday when I pick through his food all the time, which I wouldn't give to a dog, I found a little heart because my brother was a veterinarian, and I know what it looks like, and it had all the valves coming out of their little heart, and I think what they're feeding these people are byproducts, which you would give a cat or a dog. And when I complain and I tell the head administrator here or the nurse, the head nurse, all they say is, oh, that's too bad. Like nothing ever gets done. The utensils here, I have to bring in his own now because I picked dried food off of them, or I have to go and scrub them down before he can eat out of them, which I no longer let him do. I found hair in his food so many times, and he's just not well cared for. He really needs to be in a dementia facility, but everyone I have visited, they tell me there's, a 2-3 year waiting list, or there's 350 people ahead of you. And he's 83 years old, and by that time he'll be long gone.
So, Mary, thank you for the call, and I'm so sorry you're going through this. And unfortunately, there are good and bad facilities out there. So I'm going to have you do a couple of things. One is, my suggestion, I think Peggy would agree, is there is an ombudsman for convalescent homes. Have you gotten them involved?
I will, because my daughter just happened to have furnished me with the ombudsman's number.
Yeah.
So next week, when he's available working, I will be calling him and letting him know of the conditions here. But as you said, there are good and bad nursing homes. But until you're actually in a nursing home, you have no idea how it's run. And when you first go in, everything looks nice, everybody's happy, everybody's attentive, until about a week in, and then you realize all these things that aren't right. And I feel sorry for the people that have no one to come and stay with them or visit with them or see what's going on with them. And I am here now, and I am here 8 hours a day, and when I leave, my daughter comes in for another 8 hours at night. We cannot afford to leave him alone, and I am thinking of hiring somebody to stay with him from the 11 to 7, because that is the worst shift.
So, Mary, do you, this is your brother, you said?
No, this is my husband.
Your husband. So, and your husband has Medicaid?
Yes, he's on Title 19 also.
Right, and so that's a little more difficult to make a transition into another home. But so I would call the ombudsman, but when I get off the phone with you, I want you to stay online. I will have Christian take your personal information, and I will hand it over to Peggy. Peggy Sayers, our representative, is here. I'll make sure that she finds out more information from you and get your legislator involved. I encourage that with everyone. When I hit a wall, which is very hard for me to hit at times because I do push things along, I always call my local legislator. Their office is filled with people to help for issues like this. This is an election year for a lot of people that sometimes matter. But what are your thoughts on this, Peggy?
Well, also, if you call the public health department, they have a complaint division, and they will go into that home and investigate the complaints that you have made, and they will follow up on that. They will do a report, and they will get that information back to you. And I think part of what I heard from you is that you get no response when you talk to the people in the home.
No,
and that's extremely, very, very frustrating. I know anytime when you don't get response, when you have real concerns like the ones that you have voiced today, that's really, really difficult. So I would call and definitely make a complaint.
And also know, Mary, that they will go out when they consider it a safety issue, because I have lodged a complaint only once, but when I did that, they will go out immediately to that home and take care of the issues. So I agree with Peggy. Your ombudsmen, who are hard to get because they have a big job. I think there's like 4 territories in Connecticut, so there's only 4.
Right.
And call the public health department. I'm going to see if Christian can get that number for you. Mary, we have another person online. I want you to stay on the phone. Christian's going to take your personal information and also get you the public health phone number for you to call for a complaint. And you will hear from Peggy.
All right.
Thank you, Mary. Appreciate the call. We now have Linda in Windsor. Hi, Linda. This is Sharon. How are you?
Hi. How are you?
I'm good, thank you. Thank you for calling.
Yes, I have a question for Peggy concerning education and where things are going with regard to AIDS. I'm a registered nurse, and I've worked in home care a long time, and I'm concerned about them talking about AIDS, giving medications. That's part one of my question. The other part is, what is happening with the education with RNs? I've experienced a lot of situations out there where it doesn't seem like the RN has all the education they need and the knowledge to make the proper decisions, such as in an emergency, something like that. I don't know if, the state has answered the nursing shortage to, letting less education happen for our nurses.
Well, and actually I don't think there's been any changes in terms of the nursing education. But let me start with the AIDS. And the question was around the medications. it's very interesting in that legislation was put in by the Department of Social Services for a number of years to the Public Health Committee to allow the home health aides in the VNA types of agencies, the licensed agencies, to administer the medications. And the reason why they did this was the high cost. We have many people that have chronic mental illness, and a nurse goes out once a day or twice a day to administer their medications. So the legislation was put in because there are nurses that serve on the Public Health Committee. That has never gotten anywhere. We were able to work with our colleagues and have them really understand that this was not the way to go, that the assessment piece that the nurse does when they go out to administer those medications is so much a very important part of that med administration.
I agree.
And then a couple years ago, I think it's been 3 years now, legislation was put through the Human Services Committee, and that is from the Department of Social Services, and there isn't nurses serving on that legislation. Well, the legislation actually got out of committee, but it didn't come out as a single bill, and it was placed in an implementer in the budget bill. And so there's not a lot you can do sometimes when those things happen. It's sort of hidden in there, and people don't have a lot of time to explore through. I think this year's implementer was like 600 pages in terms of determining every little piece and nuance that's in there. It's taken up to 3 years to begin to implement that and come up with a training program for those home health aides. And I still have major concerns because many of our people with chronic mental illness really need that daily assessment, and it's not really safe for the home health aides to be administering those medications.
Yeah, I remember even years ago, and this is going way back now, when LPNs were not allowed to administer IV medications, and I still feel that their education level is such that I don't know that they really understand the process and what's actually happening with chemically and anatomy physiology wise when they actually are administering IV medications.
Linda, we're going to have to cut you short. We're here every week from 11 to 12. Thank you for your questions. We're honored today to have Peggy Sayers on board. Thank you for the call, Mary. We'll follow up with you. You're listening to Revolution Healthcare Radio.
Have you found yourself facing a million difficult healthcare issues? Tune in every Saturday from 11 a.m. to 12 noon for Revolution Healthcare Radio. Get answers. Saturday, 11 a.m. to 12 noon on The Talk of Connecticut.